All right. I say, Ashley, if you can share the agenda.
Yes, ma'am.
And Jen is here, so I'll turn it over to Jen and Michelle.
Good morning.
Hope everybody had a restful weekend.
Happy Mother's Day to the moms. All right, let's go ahead and get started. It looks like we have 1, 2, 3, 4, 5, 6, 7. I'm counting 7 members. Is that accurate?
I'm counting 9.
You, Michelle, Joy, Scott. Oh, Donna.
I say
Katie.
Joy is not a board member.
Joy is not. Why did I think she was? Because you're here
I
every
hang
week.
out here all the time with you guys, and I'm
I
very
just thought the
interested in what
same
to
thing.
support officially.
hmm
Okay, so it looks like we do have a quorum. If everybody wants to review the agenda and let us know if you have any additions or questions about any of the agenda items. If not, we will move on to the minutes for approval. If everybody wants to take a few minutes to review. Jess sent those to us last week.
Who takes those minutes? They're really good. I read through them on Friday. They're really good. Whoever
Those
does
my
that.
fantastic team members, Ashley and Taylor. They are amazing.
Fantastic. Thank you, ladies, for doing such a great job.
And say, Ashley or Taylor, are you able to share the April minutes on the screen?
Yes, give me one moment.
Samantha, you've got your hand up.
Yeah, I have a question slash concern about 2765 statutes that's come up as a result of current legislation that might be good to discuss with this group. And I don't know if there's time in the agenda for that right now or later or what, but I wanted to flag it while we're looking at agendas.
Yeah, we can absolutely add that. Maybe we'll handle that first before we jump into our impatient guests that are here.
Cool.
This is Ruben. I would move that we accept the minutes as noted.
I will second them.
Beautiful. April minutes approved. How was the in-person meeting at university?
I thought it was good. I enjoyed myself. Yeah, we had I was trying to remember. Dr. Rice and Kelly was there. Yeah, we had 4 or 5 people, and then we did a tour afterwards. We took a look at the ED inpatient units over at University and walked over to Cedar as well, and sort of met some of those frontline leadership teams and asked lots of questions about 2765 and patient movement and referral processes. And so it was a nice morning, and then I'm glad lots of people could log in. I think Sean Hansen was there in person too. Okay.
Very cool. Thanks for hosting.
Mm-hmm.
All right. If we want to move on to Samantha's input on the 2765. Was it the amendments that you said?
Oh, it's just a question, concern about existing 2765
Oh, okay.
statute that will not be amended by current legislation.
Okay.
So all of the, and this came up because of some of what's in the proposed legislation or the almost finished legislation by now. But
yeah,
all of the language around emergency mental health holds and emergency transportation in particular in statute allows for anyone who's providing that kind of emergency transportation drop off at any emergency medical facility or any facility designated by the commissioner. And this came up because a lot of facilities designated by the commissioner do not receive crisis or emergency admissions. And there was new language in this bill that was concerning, that was similar but different. And the argument was, well, this is what all of the language says. Anytime, especially law enforcement, is transporting someone to a designated facility, they can transport to any designated facility. And so in order to align with current statute, we shouldn't be narrowing this down to designated facilities that are licensed to accept emergency or crisis admissions. And I'm just wondering if that is something that, like, statute-wide is concerning to others, or we should be looking at or flagging, because I am a bit concerned, not only as someone who works with hospitals that do not receive admissions, like walk-in admissions, but also just in general, that people who are in crisis are going to facilities that are equipped to manage a crisis, if that's like language that we should be talking about or looking at.
Which statute are you referring to, Samantha? Or which piece of legislation are you referring to?
So the Senate Bill 149 had language that it was added to these emergency mental health hold statutes that was specific to individuals who are detained in jail and the capacity for jails to transport those people to designated facilities. But the argument was that that's not different from existing statute, because existing statute allows any law enforcement to transport to any designated facility.
So this one calls it out separately? Is that what you're saying?
I mean, this one was particularly concerning to us at the mental health hospitals, because we feel like jails are more likely to try and drop off at the mental health hospitals. Whereas, you know, if someone's in crisis in the community and law enforcement picks them up on an M0.5, I doubt they're going to be like, let's take them to SimHip. But legally they could.
It's not entirely true, is what I will say. I have to dig into 149 to see what it says about the jail transportation, but at least under 2765-106, it says any designated facility for emergency mental health hold. So it has to be designated to care for an emergency mental health hold. And so that's not going to be just any designated facility.
Can't any designated facility have an emergency mental health hold?
So the way that we do it with BHA, if we are designating you to provide processing of an emergency mental health hold, that is a different approval than just being any intervening professional in the community that under statute is allowed to place the emergency mental health hold. So there's a slight difference. So we're talking, I always like to use like a school social worker as an example because that's where I used to be. So like a school social worker places an emergency mental health hold. They're not just sending that person to like the nearest outpatient clinic, right? Like they're calling for assistance either through EMS or law enforcement to help transport. The expectation is that they go to an emergency department or like a walk-in crisis center, any place, ATUs, places that can accept individuals on an emergency mental health hold. So it's not necessarily going to be like SimHip or Fort Logan or any of those places. We even had conversations with our designated providers who have an outpatient designation at a location. And they were like, well, we can just hold on to them until like we can find an inpatient location. I was like, no, that's not how that works. So there's still a lot of education that needs to be done, and we can still provide that. Like we have trainers. Part of the fiscal note in this Senate Bill 149 this year is we actually get a part-time trainer temporarily. So we have some pretty significant plans in place. And Samantha, I know like Ryan Templeton and some other BHA leadership are going to work with OCFMH leadership, say that 4 times fast, to come up with like an implementation plan for some of these concerns. Because it's a big bill and there's a lot of things that are going to be moving.
Right. Well, and honestly, I'm not as concerned about the implementation of this bill. I am concerned about trying to implement everything in this bill. We've talked through our walk-in admission policies and all of that. Like we're preparing for that particular piece of language. It just called my attention to the fact that the language seems very ambiguous throughout the statutes, and that's why I brought it here. Also, interestingly, like take the person into protective custody and transport the person to a facility designated by the commissioner for an emergency mental health hold. That for an emergency mental health hold, like whether it's attached to what they're being transported for or what the designation is for, is super unclear as well. And I think that's also problematic, especially since, as you say, like there are different types of licensure or designation or whatever around those mental health, because it's not like we can't hold a mental health hold.
Yeah, and I think that the biggest thing is really, and since BHA is really responsible for this section of statute, we can absolutely make either like a frequently asked questions or really focus our training efforts on not coming up with, but because we have some of these already in practice, really finalizing and solidifying that messaging that this like designated by the commissioner for an emergency mental health hold means they have been designated and approved to provide services for individuals on emergency mental health holds. So we can add some clarifying language as far as how we train, because that's always kind of been our practice around this.
Great. Thanks.
Yeah, let me know what other stuff you find that is concerning and we can prioritize it.
It's amazing how like when you are like, I don't know about this new thing in this bill, it's always like, oh, but it's already in statute here, 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 and here. And you're like, oh, great.
Yeah.
Yeah, I would just say sorry, go ahead, Michelle. Oh, as an attorney, this issue has come up a lot, like working in the mental health field. And I do think that designated by the commissioner for an emergency mental health hold is ambiguous. And even if the BHA has their stance on what that means, that doesn't mean the courts have to interpret it that way, especially as written. But I also have a question, and if the BHA has a list of the facilities that are designated specifically for emergency mental health holds, because I know there's the list of the short-term, long-term, outpatient, inpatient, but it would be really helpful to the courts to have a list of the emergency mental health holds so that they know when they get a 106 petition where they could send someone. So they're not sending them to the wrong people.
Yeah, and we absolutely, it's the exact same report that I would run for that inpatient versus outpatient designation. And so that's not a big ask or a big lift that we can make that available. I think the challenge is we need to make sure that there's communication happening between the courts and that provider so that people aren't just like showing up. So, for example, like Centennial Peaks is approved for emergency mental health hold processing. It's a terrible word, I know. But they're not a walk-in center. So people aren't walking in, so to speak, right? But they work with a lot of the emergency departments nearby to accept people on holds. So it's going to be one of those kinds of things of like if the court has someone that they want to be evaluated under a hold, like they just need to work with that facility directly. We do have some things in this bill that increase care coordination. And so like that's one of the things that BHA is working on internally. And we will have all of that messaging out as soon as possible as to what some of these new processes are going to look like. Because it is a pretty big change coming with this bill.
Yeah, I guess, yeah, just kind of a piggyback off Katie's statement. I mean, I guess I have a couple thoughts. So one is, to what extent does the BHA want these regs to push accessibility? Because I mean, I think you're saying that, hey, we have these rules for managing emergency mental health holds that doesn't necessarily obligate facilities, for example, Centennial Peak, since you mentioned, to provide those services. So is the BHA saying, hey, we want to designate because we think these facilities should be providing 24/7 unscheduled walk-in visits, and they're not right now? And I think my guess is the answer to that is the BHA expects some of these facilities to do that and others not to, and maybe the regs haven't caught up to that nuance. And then the question of coordinating with the courts, I don't know. I mean, that's more complicated out. Like, it's of course always great if you get a heads up from the court, but like in practice, I don't know, Tommy K, like people get put on a 106, they've got to go somewhere. Like you can't, like I don't know. Like in practice, the idea that you have to have coordination doesn't really bear out. Like you just need to get the person somewhere safe, and then you can do your assessment and call back.
Right. And BHA does not have regulatory authority over the courts, right? So for us, it's really that training piece and then working with our designated providers to partner with their local courts and to have these kinds of processes set up ahead of time so that they understand that, like, hey, you have agreed, like, we didn't tell them, Centennial Peaks, for example, you have to take people on emergency mental health holds. That's part of their business model. They are not a comprehensive safety net provider, they are not an essential safety net provider. So that business model for them is something that we coach around of, hey, this is the services you say you're offering. These are some of the things that are going to happen. So a court could order someone to an evaluation in your facility. What are the policies and procedures? How do you manage this? What are some things that you can do? So they have their own internal policies around, like, if this person is, beyond their control, they're a psych hospital. There's usually not, like, they're one of the highest levels of care. Right, like we can assist them and provide some technical assistance directly to them, but there are other things that we do ahead of time to help prep them and prepare them around what we expect them as a provider who's offering that service. So we do have the rules and regs that kind of lay that out. Because of this bill, I was actually just working on this morning, we will be revising all of that chapter 11, right? So there's going to be additions to that chapter. We actually pulled chapter 11 back from the ASAM implementation timeline. So we will have additional stakeholdering this fall for that chapter for some of these changes and expectations. One of those is going to be around the jail services. So we have lots of things coming. I just say, like, keep up to date on the website. We will send out a bunch of communications as we can. I do have like plans for specific memos to come out at specific times. So we have kind of a rough framework right now. There's a lot of things we cannot implement until the bill is signed. So we just ask for everyone's patience, but we will provide as much guidance and training as we can.
Well, Jessica, I'm sorry, just one last comment. I mean, I think I appreciate the response. I think it sidesteps the issue that's come up in this room before, which is, so the BHA, right, can educate and whatever, but what happens is that facilities pick and choose what services they want to provide based on their profit motive and their business model. And so they can say, well, I want to pick these types of 106s or these types of patients, and the result is a big access issue. And so I think my question was, is BHA, like, you're saying you can do these things, not that you have to do these things.
Yes. And the reason we did that is we wanted to have providers with those, but not this is going to sound bad.
Yeah.
Let me try and phrase it as best as possible. We didn't want to provide designations and just say, like, you get to pick and choose what parts of the 2765 statute you're going to follow. So part of their designation approval is us working with them directly to say, which services are you offering? Here are your specific requirements. Here's what we audit you to every year. If you're not fulfilling part of your designation, they could potentially lose it. Yes, there is an access issue. Yes, the system is not perfect. One of the other things we are doing, because we are getting repeated complaints from our hospitals that our outpatient providers are not accepting certifications. So we have other issues that we're also tackling. BHA is doing the best that we can with the limited service continuum we have, right? There is limited monies this year. Everybody's kind of facing the same budget reduction. So we're doing the best we can, and I know it's not the best that people deserve, is what I will say. That doesn't mean that we're going to stop trying. That doesn't mean we're going to just give up, but we are going to have to work within the limitations that we have. And I know it's not the best answer. It's just the truth of the situation right now. Anybody have anything else before we pivot to our special guests?
Doesn't sound like it.
Okay. Ashley, if you can pull up the questions, and I'll kind of turn it over to Jen and Michelle to introduce like where this topic came from and kind of what we're looking for in this discussion.
Oh gosh. Michelle, help me remember. Did we lose her?
Sorry, with the inpatient discussion?
Mhm.
This goes back to what we kind of brought up last time with the question we were having about inpatient acceptance criteria. What can we expect for discharge? These were the questions. Is this the one that we sent the questions ahead of time, Jess, right? Yes. Yeah. What is intake like? Just all the questions we just constantly. So for those of you, we're going to let you introduce yourselves from the facilities. But for the last year or so, with every conversation we've had, somehow someone will ask, well, what do the inpatient facilities do once my M1 from an ER graces their doorstep, right? What happens at discharge? How do they get back to our community? There's always these conversations that tend to come up. And so we finally just said, let's invite some of our inpatient folks. And you got the questions ahead of time, and here they are. If there's a link to that, whoever is sharing that, would you mind dropping the link to that in the chat? And that way, if we want to jump on and look at it, we can. Am I hitting the nail on the head here? Or am I totally off the mark with?
No, now that you're saying all that is ringing a bell, yes.
It's just come up, I think, in so many different conversations that we finally just said, let's just have them come talk, because no one from the hospitals, short of Dr. Rice and Dr. Simpson, I think, are the two big ones, and you, Jen. But I think y'all are the biggest ones. And we just wanted to know across the board, kind of, let's get some input from the folks that are actually at these facilities. And this was the list of questions that was sent to them ahead of time. I'll shut up
Yeah. So I will just start with who's on my screen first. Brad, I'm not going to try.
That's all right.
Okay.
Showstrom. It's like SH.
Okay.
Yes. Swedish.
Thank you
Thanks for having me.
coming. Yeah.
Yeah, I'm at Porter.
You're at Porter Hospital. Okay. On the inpatient unit, I assume?
Yeah, I'm the director of the entire service line for the region. So we have all of our behavioral health services are primarily concentrated at Porter, 32 adult beds, 14 older adult / geriatric, and we're looking to increase that. Then we have assessment teams in all other admin health facilities. So thanks for having me.
Thanks for being
Repeat
here.
that. How many beds do you have?
32 adult and 14 geriatric.
Very
We're
nice.
But no
looking to-
adolescent, right?
We do not have adolescent.
That's what I thought. Okay.
We are looking to expand our geriatric bed capacity to
That would be
17.
amazing.
Yeah, I
And
mean, people say this regularly, but we are literally full at 14 patients virtually every day. So we recognize there's a need. We have to convert, frankly, some of the psychiatrists' offices back into patient rooms. So people don't like to lose their space. I
Of
understand that.
course.
And what constitutes the geriatric versus an adult bed? I assume neurocognitive, age,
Age,
combination of the
65 and
both.
above.
Okay.
And then if a patient requires like a medical bed, they would go on our older adult unit, because our adult unit, we have a limited number of medical beds. So medical comorbidities as well. But typically it's age. I mean, we'll put some older adults on our above 65 on our adult unit too. So there's some interplay.
Sure.
And then we also do electric convulsive therapy and have a whole complement of outpatient programs, intensive outpatients, transcranial magnetic stimulation, med management.
How frequently do you do ECT?
We do ECT on Monday, Wednesday, and Thursday.
Okay.
We have anywhere from 15 to 25 patients on those days. We do both inpatient and outpatient.
That was going to be my next question. Thank you.
You're welcome.
What other facilities are represented here? I love that Porter's here. We use your geriatric admission site a lot.
Oh, thank you. We appreciate that. And if there's ever issues, please reach out to me.
Looks like Lindsay Gaffey from Children's.
Yes, there are a few of us on the call today from Children's Hospital, Colorado.
Beautiful. And we know you take children.
Yes, we do.
Who else is here? Just so we know the scope of all the facilities represented before we ask a ton of questions.
Kimberly Klein from Denver Springs.
Yep. Hi, I'm Kim Klein. I'm the Chief Operating Officer for Denver Springs. We have 96 beds, 4 units. One of those units is an adolescent unit for 13 to 17-year-olds. That's 24 beds. One is a detox unit, 24 beds. The other one is mental health or wellness. And then the 4th unit is a heroes unit, specifically targeted towards active duty veterans, frontline healthcare workers, or first responders. We also have IOP and PHP at 3 locations.
Let's see. Martin Aaron.
Yeah, hi, I'm Martin Ahern, and I'm a psychiatrist at the Colorado Mental Health Hospital in Pueblo.
Oh, nice.
What is the layout of your facility, Dr. Ahern? How many beds, adults, children? Just a really quick overview.
So we are the forensic hospital down in Pueblo, and so we have, I think, around maybe 400 to 500 beds. There is an adolescent unit, but if you've been on email threads, there's discussions about that relocating to Fort Logan in the near future. And we do have 2 geriatric units.
Beautiful.
Other than that, it's an adult, primarily adult population.
Beautiful. Thank you.
And then Lindsay Saunders, and it's cutting off the second last name, so I apologize.
I'm not here from any facility. I'm here from the JCC from Arapahoe County.
Oh, perfect. Okay. Thank you. And then Jody Finney.
Yes, I'm here for Children's Hospital Colorado.
Okay. Poundsra.
I assume you're referring to me, the pound.
Oh, Dr. Pounds. Okay.
Yeah. So
Got it. Nikki Esquivel Potts. Or Sean Hansen.
Hello, Sean Hansen here. I am a member of the board representing myself with lived experience. I do work at Denver Health, but I am not representing an official.
All right. Did I get everybody representing facilities? And then I guess I'll say I represent Fort Logan State Psychiatric Hospital, the other state hospital. Okay. So do we just want to go facility by facility?
Can I ask if everyone would just take a really quick scan at these questions because I'm looking at the time and there's only an hour. If there's anything in these questions that anyone just has a burning desire to jump to rather than going in order, maybe just ask, hey, number 12 is really important to me to know. Otherwise,
Hey,
as
Michelle.
y'all, yes.
Sorry, I said the highlighted ones are the ones that we as a group decided were our priorities.
Fantastic. Thank you. Okay, that's it. That's what I was assuming because I'm like, I know we talked about number 12. Then yeah, Jen, I like your idea of just going facility, phrase the question and go facility by facility.
Okay. We already started with porters, sort of, so let's go back to porters.
Great. So you want me to answer all the questions on the highlighted ones?
Yes, that would be lovely.
Okay, can you scroll up, please? I only see 5. Or was there any above 5 that were highlighted?
There we go.
Number 3, discharge planning. Social workers, they connect to depending on the funder, right? If it's Medicaid, and if they're on a certain short-term certification, it would be one of the safety net providers, typically the old community mental health centers, although I do realize there are some new ones. Across state transfers and discharges, well, we do our best to get the patients back from where they came. And if that includes paying for their transportation, we'll do that. So we contact a family provided there's a release. Some patients don't want their family involved. And then we certainly contact outpatient providers, psychiatrists, med providers. And then if it's a new facility, we would contact that facility. Certifications, experience, it's been mixed. Hopefully it's improving. Sometimes there's been a reluctance to take certifications, and I think it's gotten better. So we like short-term certs and we like to transfer them. All right, how are we contacting loved ones? We get a release and we'll do our best to track down support. What is your awareness of the exceptions and well, if we're trying to figure out who someone is or get corroborating information, we will, and if they're on a mental health hold, we'll contact family, sometimes without a consent, but we won't divulge much information. BHA Friends and Family Form. I think we're using it. Exclusionary criteria. This is a very valuable one. I think the big struggle, I would say everyone will agree, is those who have primarily developmental disabilities and those who have traumatic brain injuries and their behaviors manifest as psychiatric. It's not that we won't take them, but there needs to be some psychiatric condition as well. Dementia can be challenging too. We try not to take purely patients with dementia on our geriatric unit, but sometimes we do. And medical capabilities and limitations. So we're a general medical hospital. We can take pretty acute medical comorbid patients because we can transfer them to our inpatient units, which we do regularly. We don't have a stringent medical clearance, frankly. If there's labs are indicated, we want those done. Lithium levels, Depakote levels are great. Drug screens, if indicated, are spectacular. How do you handle clients that are unhoused? Well, we try to find them housing, and whose responsibility is to ensure aftercare follow-up. So like I said, we have a very robust team of social workers that discharging is their forte, and that's what they primarily do. Yes, Lyft and Uber, we try to avoid that, but if need be, we will use Lyft or Uber. Thank you. I know that was very quick, but please, questions I'm happy to answer, or someone else may go. Barring no questions, I'll go on mute.
Okay, thank you so much. We appreciate it.
You're welcome.
All right, next let's go to children's, and we've got a few people on. So if you guys want to draw straws, I don't know.
Yep, we were doing that via text message, and I drew the short straw.
Okay.
Just kidding. Happy to represent us, and Bo and Jody are also on, so please contribute to the conversation as well. So for number 3, what is our discharge planning and process? We too have designated roles. We have behavioral health placement specialists, navigators who are focused more on community-facing food insecurity, any applications, and social workers. All of our patients have an appointment within 7 days of discharge, and we're contacting any agency, prescriber, school that's involved with the child's care. How are we contacting loved ones? That one is, more straightforward for us because we treat children all the way down to prenatal, perinatal, up to 18. So the family and loved ones are a key part of the experience. And let's see. Types of exemptions and statutes. I don't think we utilize exemptions and statute for contact. Number 5, what's our exclusion criteria? We don't have any, I guess a couple exclusion criteria that are more set for us. Like we can't, on our 2765 unit, treat patients in like active detox, or if they're not medically cleared and they're not medically stable within the competencies of our nursing, if they would not benefit from, they need to meet inpatient criteria, and they need to be able to benefit from an acute psychiatric admission. But otherwise, we don't have real hard and fast exclusion criteria, other than I guess like if you're a 20-year-old, we wouldn't take you due to an age perspective. Number 11, medical capabilities. And Jody, I'll ask you to weigh in here too if you'd like, or Bo. Kids have to be medically cleared when they come to our unit. We do a little bit more complex medical care than previous organizations I've worked in. We can manage pretty complex diabetes. We do nutrition restoration, some eating disorder type treatment, although we are careful about what's in scope and out of scope. Seizure disorders. We take a wide variety of comorbid medical conditions, again, as long as it's within medical clearance and it's within the competencies of our nursing. And Jody, did I miss anything there?
No, I was just going to add that we're in the process of working with our hospitalist team to get 24/7 coverage dedicated to our inpatient units. And so that might expand some of the medical complexity we're able to take, but there are other medical things we're able to take. As long as if it's a chronic condition that is pretty stable, we can usually accommodate a little bit more.
Thanks, Jody. And handling clients that are unhoused, that's tricky because usually it means that the family would be unhoused. So we work within our care transitions and navigation team as much as possible to help with that. We do not discharge clients via Lyft or Uber, really ever, even if they're consenting to their own treatment and are of age to make that choice, just the nature of what we do within pediatrics. And one thing I guess I was going to share, some of you all shared more about your organization. We have 32 inpatient beds, 26 that are general, 6 that are for kids with autism with severe problem behavior. And then we have pretty much the entire range of services. We have almost 100 PHP spots every day, 50,000 outpatient visits. We're in integrated care, schools, primary care, etc. But wanted to share just a little bit about the services we provide. And let me know if you have any follow-up questions, or Bo, if you'd add anything, let me know.
I could not find my mute button quick enough, which is why I usually just keep it off. But I'd like to go back to Brad and then Lindsay as well. But when you say that for both of y'all, well, Brad, you mentioned discharge, you work with the community mental health centers for discharge planning. And then Lindsay, you said they have an appointment, did you say within 7 to 10 days of discharge? I think, whatever. That it probably more for Brad, I think. Are your folks, are any of them discharged on any sort of certification, court-ordered injectables? And is there enough time with discharge to get them to their provider to be able to get those appointments so that they don't miss anything? And for those still coming, that would kind of be one of my other questions. And then all of the facilities are on the Front Range. And so those of us out in Durango or Telluride or, Glenwood, Grand Junction, we've got quite the haul for anyone to come pick people up. And some of the feedback we get from families is, we're told our loved one is being discharged tomorrow and the highway's closed. I don't know that it was children's, but we did have a kiddo that was discharged, and the hospital basically said, you have to get here to pick them up. And they said, I can't get there. And they said, well, they're discharged as of tomorrow. There's no more coverage for them to stay. If you don't pick them up, we'll have to call CPS to come hold them. Can you talk about some of those extenuating circumstances with certain individuals that have challenging things that need to be done when they're discharged, like physician orders, injections, appointments, and then those extenuating circumstances for discharge?
Yep. I'll start and then I'll hand it to children's. It sounds like it was a children's incident or an incident involving a child. I don't know if it happened to children. So yeah, we'll transfer a short-term cert and involuntary medications to whomever. Typically it would be the mental health center. That's where the patient resides. And we get patients from all over the state. If the person's unable to be retrieved, to be picked up, we would keep the person. And sometimes we send them, since they're adults and they have autonomy, sometimes we'll send them on buses. But we certainly prefer family or friends. None of us really. These are some last resort things, right?
Sure. Like
they need to go back to Pueblo and they have no one to get them. So, but yeah, we would love all short-term certifications to be transferred over seamlessly. And yeah, it's the appointment within 7 days. That's an insurance requirement, HEDIS requirement. So all the facilities are doing that, getting those appointments within 7 days of discharge. And the mental health centers tend to be quite accommodating. They have entire teams they're the hospital liaisons, and so we work closely with them.
Yeah. Beautiful. And then the last question I'm going to interject before Children's starts to speak is, there are a few, now that mobile crisis is a huge thing in the state, there are a few freestanding crisis centers that are not community mental health centers. And I think most of them try really hard to send folks to any inpatient facility. So for all of y'all that are going to talk, they try to send a release of information to say, can you please include us in the discharge just to notify us? Otherwise, they really rely on family. What is the communication like within all of your facilities? What is the communication like that would allow more than just the basic community mental health center in that area to be called and noted when that might not be the one that catches them?
Yeah, I think some of it, we aren't fully aware of who all the safety net providers are, in all honesty. So if someone has a list, they can send me, because we just don't know. We deal primarily with All Health, and they have a crisis stabilization unit we'll get patients from. Sometimes we'll step patients down to them. So the other ones, I mean, I know there's Paragon, but we weren't fully aware of them. So we ran into some issues with communication with them because our psychiatrist had no idea who they were. We want to talk to everyone. We want to involve whomever wants to be involved. We don't want to be a black box. We want information in, we want information out. I mean, we are sensitive around the releases. So, and patients can refuse to just not release information. So we adhere to their refusal, but we'll continue to try to persuade them because we want to get them connected.
Thank you.
You're welcome.
All right. Next would be Kimberly Klein, Denver Springs.
I think actually my answers are not going to be that different from Brad's, really pretty similar. I think with the exception of our facility, we do not have capabilities for more patients. We're freestanding. Medical acuity is a bit lower, so some of that can be exclusionary for us. I would also say similarly, IDD and DDD is a struggle. It's not a hard exclusionary factor. We focus a bit. I mean, the mental health has to be the primary on it, not specifically, IDD, DD, or autism diagnoses. It would have to be mental health primary. Although we can look at, adaptive functioning if that's available for us to see. So it's not a hard no, but it's more case by case, and a provider will look at it when we get the referral, or we can try to look for placement at someone that's a little bit more appropriate. And then we do not see Gero clients with psych primary either. So we'll often refer to our partners that do. Let's see, medical I covered. Yeah, and I would say everything else is pretty much in line with what Brad was also saying. If there are specific questions, or the only difference really I would say is our Heroes unit, because we're coordinating a lot with the bases like Buckley, and they have their own very specific discharge processes and coordination of care. So
I have a question about your Heroes unit. I know you said active duty and frontline healthcare workers, but since the VA has an inpatient unit, I guess what was the thought behind having you have a specific unit dedicated to them?
Yeah, the bases also have, so the Help for Heroes program is actually a national program. So the bases will often have their own beds too, but sometimes they get too full. Same with VA. Or if there is a preference for outside of the VA necessarily, so that can also happen. It's a pretty specialized program, so it can be for inpatient stabilization, and then there's always also a kind of a 30-day residential program. for them that's very focused more on trauma and care return to post, and they're actually on post while they're here. So yeah, for the active duty folks. So, and then we've it's expanded into, you know, frontline healthcare workers, teachers, first responders. So we've got a lot of police officers that may come. The idea being that they can get treatment outside of being on a unit with someone they may have had to work with in the community before. So it's a bit more comfortable for them.
Interesting. And then do you bill the VA?
It depends on if they're active duty veteran and their insurance, really. It comes down to insurance. Yeah. But we do take TRICARE.
A quick question. Have you had issues with VA reimbursement, Kimberly?
There are a lot of holes that we
Okay. At least we're not. Yeah, they seem to have pared down their team over the past year, and it's
yeah, definitely. I think
do you know
we've
anyone
got
over on the reimbursement side, Kimberly?
yeah, we've got a pretty good UR team that works a lot with them, and I think we've gotten a pretty good process. But there are definitely a lot of special requirements, I would say, that we run into.
Yeah. No, it's been more challenging the past 12 months, particularly with electric convulsive therapy and transcranial magnetic stimulation. All right.
Denver Springs does not have ECT, correct?
We don't currently know.
All right. Any other questions for Denver Springs at the moment?
I'd say the only other, sorry, just to add, the only other different thing is because we have a detox unit, so that discharge process is just a little bit different. Really, it's depending on what the client needs are. They may discharge to a residential facility or step down to outpatient level of care or dual diagnosis treatment. So that's the only other difference, really, I would say, from Brad.
You all are 3-7, right? 3-7 designated, Kimberly? Yeah, okay.
All right. Next, I think we have Pueblo, a couple folks from Pueblo.
Yeah, it took me a bit to get the mute too. Let's see, what is your discharge planning process? Who is our social work department? That would be Renata Zacharias is the contact person. What? I don't know what would be what. How it's again depends on the individuals. We have the NGRI patients who are here one day to life, have to go through a complex court process to work their way out, increasing their level of freedom as they go through. We have no direct civil admissions. All the civil patients on our grounds are people who came here with criminal charges. Those charges are dropped. And so again, we go through similar processes that are for any other civil hospital. That's just more complicated because they typically did bad things to get here and not many people are wanting them for placement. Let's see. How are you contacting loved ones' family? Um, well, we use the information available. We try to contact anybody and everybody who might be interested. And yes, HIPAA is the limitations. 5, exclusionary criteria. Since we do not have control of people who are admitted to our hospital are largely meaningless. We have the same standard exclusionary criteria that any acute inpatient hospital will have. But if a judge orders us to bring them in, they come in, short of violation of EMTALA due to instability. Let's see. What else? 11. Medical capabilities. We're an acute care psychiatric hospital. We have outpatient level of care available. We have numerous consultants on staff and in the community. But again, anybody who's not medically stable need to be stabilized before sending them to us unless the judge forces us. And then people we can't handle, we send to our local general hospital, UC Parkview here in Pueblo. How do you handle clients? Let's see. Unhoused clients. So actually, that's getting dramatically better with the mental health transitional homes. We're discharging record number of patients out of our hospital over the last 6 months to a year. We're increasingly successful at that. There are NGRIs that, depending on the crime that brought them in, that the sentence is 1 day to life. So again, depending on stability, there are people here for a very long time. And again, the guys who came here after committing a felony 1, felony 2 crime and the charges are dropped, they are rather difficult to house. The only people that get discharged to homelessness are those individuals who do not meet criteria for involuntary hospitalization and refuse to sign involuntarily and refuse our efforts to provide housing. We actually only discharge to homelessness. I doubt it's more than 4 or 5 times in a year. And so again, it's not no way is it a common occurrence. And again, especially our geriatric beds are occupied with folks who the judge has sent dementia patients to us to restore to competency. It doesn't work out, and they did something horrible in a nursing facility. And no nursing facility is going to take them back as far as a nursing home. You got anything to add there, Dr. Ahern?
I don't think so, no.
Cool.
All right. Did I miss?
Question? So when they are discharged to that housing, is that primarily around Pueblo, or are there other places it's located?
Oh, it's statewide. So again, it's they're CDHS facilities for the most part. And again, so it's that's what has increased our ability to discharge patients is these homes either these options did not exist or were greatly diminished compared to now. So we discharge across the state and any place again that there's security needs. We'll discharge them anywhere. And as far as transfer and certification, oh heck yeah, anybody that'll take them, we'll transfer them.
And are there some patients there indefinitely? I know they're supposed to be evaluated on a regular basis to be released, but do you get some there for life?
And then again, we now every NGRI patient gets an annual release examination. They're assessed in that formal examination at least again the once a year. But the treatment team with these patients, like any hospital, looking at patients ready to move to a more least restrictive alternative, they're assessed every month at treatment plans. Yes, we do have people who have been here since 1995, and there are people here who have been here since before I got here.
And some sadly end up dying there, I suspect.
Yes, I'm proud of our geriatric unit. There are some people just aren't going to leave. They do a beautiful job with our people, and again, we do hospice care, those sorts of things here also.
Yeah, no, it's a necessary, valuable service.
Yep.
Did I miss any other facilities that are on the call?
And so it sounds like this meeting kind of there was some concerns about transition. Did we address all of those? I mean, it's not always, none of it always ever, sometimes it goes very smoothly, but sometimes it doesn't. So, but I think the people who are working have good intentions.
For sure.
When we have difficult to place patients.
Yeah. I guess I can answer for Fort Logan. It's going to be very similar to Porter's and some Pueblo. Discharge planning process, very similar to Pueblo and Porter's. We do try to avoid discharging patients homeless or to shelters or with a hotel voucher. Across the state transfers and discharges, again, similar. If a patient comes to us from the Western Slope, we'll either try to find that if they're homeless in the Western Slope and don't have any family to return to, we will try to get them basically any kind of assisted living or group home anywhere in the state. Contacting, same within our privacy laws, we are only able to contact folks if the patient sign a release of information. Like Dr. Pound said, the mental health transitional living homes have really helped us be able to discharge patients. I think the big difference between the state hospitals and private hospitals, we really, I don't want to say we're not allowed to discharge patients homeless, but we have a lot of patients here who don't necessarily meet acute inpatient criteria, but because of a lack of resources in the community, or maybe a patient needs a guardian before they can sign into a nursing home or assisted living, there's what we call a discharge barrier list. So those are the patients that don't exactly meet acute inpatient criteria, but for one of those reasons remains here. Transferring outpatient certifications. Again, we very much like to transfer certifications. The thought being, if a patient is acute enough to be with us, then they are acute enough to need continuing outpatient services, probably more so than most other rapid stabilization patients. Contacting loved ones and family, basically the same. Exclusionary criteria. I did have a question for Porter's and Children's that I'll get back to, but because we're not attached to a medical facility, we do have a medical clearance process. Non-negotiables, that's going to be patients who require pretty acute and significant medical treatment. Examples would be, chemotherapy or high-risk pregnancy, or if they've recently had an amputation and require additional surgeries, or any more acute medical issues we wouldn't be able to take until those medical issues are more stable. We can take voluntary and involuntary clients. Direct admissions from crisis centers, we certainly could theoretically. However, we have such a very long wait list that basically all of the stars have to align in order for us to have a bed open and a patient is in a crisis center or an emergency room, which does happen periodically. I would say maybe once or twice a year. But as soon as we have a patient discharging, we're already working on the next patient on our wait list. So some patients have been on our wait list for months. So we do have, we basically go on a first come, first serve basis, but we do prioritize patients in emergency rooms and jails because they're not in the correct level of care. And then we do take patients from the ATU, but those require administrative review just because the ATU is a lower level of care than inpatient hospital. Not to say that a patient can't decompensate in an ATU and require an increase in level of care, but that has to be the case versus, I know most ATUs have like a 2-week group criteria, and sometimes patients are there longer than 2 weeks, but that doesn't necessarily equal they need an inpatient hospital. So that's the reason we do administrative review for those patients. Medical clearance on site. We do have on-site medical physicians who do our medical clearance, but they don't do a medical clearance for a patient before they're admitted. So we require labs, a medical history, and physical just to make sure somebody doesn't have a medical issue that we are not able to accommodate. And then aftercare follow-up, we work really closely with all the mental health centers, mental health transitional living homes. Again, if a patient's acute enough to need the state hospital, they're definitely going to need aftercare follow-up. Lyft and Uber, no, we do not use Lyft and Uber. All right, any questions for Fort Logan specifically? Okay. Oh, it looks like we have Aurora Mental Health and Wellness. Is that the hospital or the mental health center? Nikki.
Hi, it's the mental
Hi.
health center.
Oh, okay. Very nice.
Sorry, I couldn't hear you guys. Bob and Gina. I couldn't hear you guys earlier. Our audio went out, so my cohort Kayla and I had to re-sign on.
Oh, fun.
Yeah, good times.
I will go through and we'll talk about the questions, and then maybe we can loop back around. Nikki, you're the only mental health center on the call, so I'm sure we would all love to hear from you. Being requested. Oh, I think Bo had to leave.
Oh, we're not Aurora Mental Health though. We're HCA Aurora. Makes sense? The hospital.
You're the hospital.
Yeah, there it
Oh,
is.
okay. So you're like
There it is.
the outpatient section of the hospital?
Nope, outpatient and inpatient hospital.
Oh,
Aurora
okay.
Mental Health and Mental Health and Wellness Center are two different places.
Did it used to be called or MCA?
Yep,
Ah, okay. Now I'm connecting.
there it is.
I didn't know that it changed names.
Yeah, we changed names about a year ago. 2 years ago? 2 years now.
Okay. How do you communicate with providers for short-term CERT and injectables in a timely manner so there is the ability for a provider to plan appropriately? I will let Porter's, that's going to be really hard for me to not say MCA. Aurora Mental Health and Recovery. And Children's answer that question.
Which one was it again?
How do you communicate with providers for short-term CERT and injectables in a timely manner so there is the ability for a provider to plan appropriately?
I think the only hindrance is the release again. If we can't get that release, that kind of ties our hands. But if we have the release, we'll call the provider as like the day of, as soon as we get the release.
I have a question. As someone that takes outpatient certifications, my understanding is if there's a certification involved, that there's not a release that's necessary. So
okay.
I'm just wondering, like, that seems to be a different interpretation.
Can we release if the patient's on a short-term cert? I guess if you say we can, I will pass that message.
I was going to ask the same question because if you're transferring the CERT to a provider,
you have to be able to
Have to
communicate. I
be,
mean,
yeah.
it's in the court. It's a loss, or it's a court order. So, for example, I can speak to the patient's lawyer without a release because it's it's a court order. So, like, a lot of my experience, at least the way I've learned and interpreted or heard them interpret these laws, is it's similar to if someone is in an emergency situation, like a hold. You can contact people
For coordination of care. Yeah.
Right, exactly. Because in theory, it is like a permanent hold. So the fact that there's not, and they're also on a certification. I mean, it speaks to their lack of insight, perhaps, of the whole process. So I don't know how, you could do it if the patient was declining that.
Right.
And you are saying that they needed a release.
Yeah, if we don't need a release, I'm happy to tell people.
Ruben, you've had your hand up for a while. Go ahead and ask your questions.
I just had two listening to all this about the different criteria for medical clearances and things. Are any of it sounds like most of the hospitals are on the Front Range, well, which is where most all the behavioral health hospitals are. Are any of you accepting field clearances from community paramedics or MIH programs? And if you're not familiar with it, I'd be interested to tell you more about it offline. It's something we do in Western Colorado a lot to avoid, individuals that have a primary behavioral health need going to the ER for a medical clearance, where we clear them with a community paramedic and then get them directly into the behavioral health care they need. Sometimes the challenge we run into is we'll run into facilities that go, oh no, it has to be done by a doctor. But clinicians with an MIH team are absolutely able to follow those clearance guidelines and even consult with a physician if needed. The other question I have, and I know we've talked about it in this group before, is one of the challenges we often run into when we're taking patients from Western Colorado, I'm in Delta, over to the Front Range, which is where they usually have to go for inpatient behavioral health, is that sometimes these patients are agitated enough that they need some kind of sedation. And so, but what we run into is, they're needing to get some Ativan. I've even a couple times back before ketamine became a bad word, had patients that they would use some ketamine to keep them just kind of sedated as we made that, 5-hour trip to the Front Range if the roads are good. But the problem we ran into is when we get over there, the receiving facility would refuse to take them if they hadn't been off of any kind of sedation for 4 hours. And so that becomes a really dangerous game when you're trying to time sedation and cut it off 4 hours ahead of time. And then about the time you're coming into Canyon City, the patient's getting really agitated again in the back of an ambulance. And you're like, shoot, if I do the right thing and give them some droperidol or anything to try to decrease that agitation, then I may end up, having to go to an ER on the Front Range, which didn't solve anything. So I guess just kind of a question, since we have all these facilities on here, of how you do that, or are there ways to approach it when we're leaving here? Because oftentimes, even if we call the facility, they go, nope, they can't be on anything. And it leaves us in a really challenging situation for patient and provider safety when we're trying to move them. And for clarity, I'm an EMS person. I'm like the lone gutter nurse on the call, I think. So um, that's where my perspective's coming from, is from EMS and transport and field medicine.
That's an interesting question. I know I mean, we definitely have a pretty significant medical clearance process, and I wasn't familiar with the, I forget what term you used, but an EMT basically doing a clearance. We do, if a patient's coming from jail, for example, and there's no providers like a smaller county jail, we do require them to stop at an ER to get lab work and a history and physical, but I guess we have never considered an EMT doing that clearance. I don't know, other
So
than the,
let me clarify for you, Jen. So not a, well, there's different levels of EMTs. When we're talking about MIH clinicians, we're talking about paramedics with a board credential above paramedic. So they're board certified in community paramedicine and sometimes critical care as well. Some of them have more than one board cert. So these are advanced practice paramedics that are trying to find the right term that won't light someone somewhere up, but they have more extensive training than your standard paramedic, even on a 911 truck. So like my teams carry, like we can do Chem 12s, we can do urinalysis. We can't do a tox screen, but like for BACs, we'll get local law enforcement to come and do a breathalyzer for us. And like our local center will accept that BAC we get from law enforcement. And that's being done not punitively by law enforcement, but just as a courtesy as a partner because they have the tool and we don't to get the BAC. So they'll come do a breathalyzer. We can do those labs. And then like we have all the criteria for our local centers, like, hey, if the person's intoxicated or otherwise under the influence and they fell and hit their head, well, yeah, we can't clear them. They're going to have to go, to the hospital for imaging. But if they're, alert and say suicidal, and there's no evidence of a overdose or ingestion situation, then it's like, okay, we can clear their spine. We can ascertain, we can do a 12 lead. We ascertain that there's not I always hate saying this because it comes off wrong, because behavioral health care is medical care, but that there's not a medical emergency and it's an isolated behavioral health emergency. And then, like you said, our big goal with it always is just trying to not overload our rural ERs with, patients that need help, but they don't need help in an emergency room. They need help in a behavioral health facility.
what would you do with the lab work though? Because that's going to take time. Is there
So our lab work, our piccolos like Kim 12s and things, those process in under 20 minutes. Like we carry the equipment with us,
wow.
and have a mobile lab.
Really?
We do them right. Yeah.
Wow.
Yeah, we could literally come to your house, do it in your living room. We can run full respiratory panels that are PCRs, but those come back to our station. That lab equipment stays at the station, so it takes us an hour to process those or whatever. But yeah, like Kim 12, we literally can do wherever the patient is in about 20 minutes.
And they just sit in the back of the rig with you?
Well, so it depends on, no, so we actually, the community paramedics run out of like a Ford Expedition, Chevy Suburban, that type of vehicle. Um, and then like they would go and do the clearance, and then we have a BHST unit with the ambulance district as well. So like once they're cleared and we have acceptance, then we have that unit come to do the transport. Unless it's the ones we were talking about where if a patient needs any type of sedation or something because they're agitated and we've got to make that 5-hour trip, then they would go by ambulance because there would be a paramedic in the back with them managing that sedation and monitoring their vital signs and their airway and all those types of things that go along if you're giving sedation of any kind.
Right. Sorry, I'm trying to keep up with the questions. Let's see. Michelle's second question, discharge for extenuating circumstances. Do you want to elaborate on what you mean by that, Michelle?
Michelle had to leave.
Oh, okay. Where is that mental health housing primarily located? Dr. Rice, do you mean the mental health transitional living homes?
What's that? Sorry, I was on the phone briefly.
Your question, where is the mental health
Yeah,
housing?
he answered it that they were all around.
Yeah, okay. I'd like to hear more about barriers, challenges with transferring certs representing outpatient providers. I understand them, I think, from that perspective, but would love to hear how inpatient providers see things. Would like to know clinical, medical, as well as if there are financing barriers or other housing, transport, treatment noncompliance, history of violence, etc. Frank, was your question answered?
Not necessarily in detail. I mean, I'd welcome a little bit more detail. I know that there are challenges that come up with certs. Like I said, I think I understand them from a outpatient perspective, but would welcome, uh, and I think Jessica even mentioned this in the topic before, that, and I think it's an area of future work, right? Under 149, we've created, I think, created more doors from criminal to civil as we should. And just wanting, I think the next step after 149 passes is to enhance the community treatment side on the civil side. And would just love to hear, I think, some of the challenges from the hospital perspective.
I'm happy to speak to that. So from the state hospital, we do get a lot of refusal to accept certifications. And so that sometimes limits certain discharge options. We are told from clinics that they either don't have capacity to accept a certification or they're not willing to accept a certification. Sometimes that's due to the patient's, I think, what they perceive to be the risk associated with the patient's either history of noncompliance or potentially their dismissed charges. Practically, I think we've all questioned the actual practical utility of continuing an outpatient certification for patients who struggle with compliance or remaining engaged. We get feedback that since we are discharging patients from Pueblo to all across the state, different counties, that different sheriff's departments either don't or refuse to enact pickup orders, or they will refuse to do it if the certification is not held within the county where the individual is. They will only do pickup orders if the certification originates from their county. So a lot of sometimes certifications, unfortunately, don't seem enforceable. And that's kind of speaking to what you were, I think, mentioning, Frank, of needing to build that outpatient network so that outpatient certification is a more robust kind of monitoring safety network for this population. But we certainly get a lot of pushback, and we have a lot of places that decline to accept certifications, and finding discharge plans where people will accept the certification is challenging. The mental health transitional living homes and Dr. Shaban has been really helpful for Pueblo in that regard.
That was a very good summary. Thank you. This is Brad, reporter. Hi, Frank. It's been a long time.
Good to see you, Brad.
Nice to see you. Yeah, I think moving forward, kind of a work group with hospitals and mental health centers could be useful, so we can kind of get all the issues out, because there's issues both sides. Enforceability, that was just mentioned, is a big one, right? If they're not enforceable, then it's, I mean, psychologically they have some weight, but if the sheriff's not going to go do a pickup, then patients realize that, and it it's not that valuable anymore.
On the one hand, it's affirming to hear nothing new, that this has all been discussed. So I think we have a good understanding of what needs to be addressed. One thing I did hear in 149 is that there, I don't know how much, if it's 1 or 2 stories, but is there a same day billing issue that comes up when somebody's discharged?
Yes.
And
Yes.
and what's the nature of that? Do you know?
I think the last I talked to one of the centers, it's been a while, that they can't bill the day of, if the patient's discharged, they can't bill on that same day.
That the hospital has the encounter for that day, essentially.
Yeah, exactly. Although frankly, we don't get paid for the last day, so in some ways I don't understand it fully. But we do nonetheless.
Yeah, it's just an issue I wanted to dig in further as we're doing some work on the financing side and want to understand that a little bit better.
Yeah, no, that makes sense.
I'm just going to throw this out there. As you know, I'm in a CBHC, a CMHC. Not Frank, not you. We don't.
We'd be glad to
you
have you,
guys
Karen.
know that we don't get paid at all for certifications. I just throwing that out there that we don't get paid, not a penny. So, just curious, if people knew that.
Sorry, you don't get paid like anything additional if a patient happens to be on a certification, or you mean you don't get paid at all?
So you can go to court, spend hours, do all the paperwork, track down the patients. None of that is reimbursed. You just get reimbursed for the visit, the actual
okay.
provider visit.
You get paid for the service, but not for the additional work.
Medically necessary services.
Yeah, there's tons of work. I'm not saying this is. I mean, I frankly think this is not a reason that the outpatient providers turn these down. I think enforcement's the number one reason, but I was just curious if inpatient providers knew that we don't get reimbursed for certifications.
For the work.
That's right.
We don't. I mean, we get a per diem, but our doctors don't get paid to testify.
Yeah, that's actually a question. So do you get paid any more than you would as an inpatient provider for a patient that's on a cert? Or that's just no, okay. So you don't either. I guess I'm not surprised. It's hard to take on these really difficult, and you're taking on a lot of risks too. It's a lot to ask to do for free.
We have 1 more minute. Are there any last minute urgent questions that didn't get answered?
And frankly, there's some changes in legislation. I suspect you've been quite intimately involved. That's going to impact transfers of certs, right?
Yes. Yep. Senate Bill 149. Yeah, I mean it's an extensive bill, and like Samantha spoke to when she first started, but I would take a look at that bill and there's nothing necessarily and the promise was like this is on the legal side, and it's about creating a door and a pathway from criminal to civil, and there was enough work there and not enough money to say let's figure out how to support the treatment side of that conversation. And so I think that's the next step, is how do we enforce certifications, or stand up a true AOT model in Colorado,
right,
to make some of this more effective. So,
well, CBHC convenes. I'm happy to come and talk about from the hospital side.
Yeah, I appreciate that. And I think this summer there will be some stakeholder meetings in addition to what OCFMH has already stood up and will continue. But I think there'll be some additional meetings this summer on this topic.
Sounds good. Thank you.
I guess the last thing I will put out there, I don't know if the other inpatient hospitals on the call are aware, we have a form if 2765 questions arise. Jess, are we able to put that link to the Google form in the chat so everybody has access? Is Jess still on here? No. I will reach out to Jess Bell. It's just a Google form that you can ask the advisory board any 2765 questions. I don't think it's on our website, but I don't think it's highly known. It's not used ever. I don't think we've ever had one question. So we will have her send out that link in the email. Anything else for this morning? Thank you for the great conversations.
Yeah, thanks for having us. Always happy to help. Anything else?
All right. Have
Jen,
a good rest of your
one last thing is that we need to open it up for public comment.
Oh, yes. Anybody else have any questions, concerns, comments? Everybody's jumping off. So I will say we are officially adjourned.
Thanks.
Thank you.
Have a good week.
Have a good day.
Bye. Bye.
Bye.